We got Richard Tallman and Jeff Riley. Everybody knows who they are. They've been pioneers in the realm of technology and education for perfusion for as long as I can remember. So they haven't turned, actually, they haven't turned as white as I have. So they're actually doing pretty good. But they're going to be in distance learning and augmented reality for clinical teaching and testing. We touched base on this yesterday, and I'm going to let them move forward. Thank you.
Well, thank you, Ty. And thank you for that introduction, but also the invitation to share some of the new things that we've been working on. Let me tell everyone this is going to be sort of a tag team effort. I'm going to share the first half, and my colleague Jeff, he's going to come in and take over the second half of our presentation. It may seem redundant and maybe even a little nauseating to have a talk about distance learning, given the current circumstances, because we're all probably pretty much tired of distance learning when we're forced into it. But it's also made us really refocus our game and give us more thought, forcing us more thought and effort and energy into teaching more effectively while we're physically distanced. And we're dealing with subject matter that's really pretty complex. And what we're going to be doing is focusing on teaching principles and procedures involved with ECMO. Well, probably one of Bill Harris's favorite topics, for sure. And how do we do that? These very complex systems, and it starts with modeling, and we have to look at some other pioneers, and Guyton was one of the earliest ones that developed a cardiovascular model, and we build on these models and we put them together into simulation platforms and simulation devices. So if we're talking about ECMO, ECMO has some simulators out there. I wanted to sort of very briefly introduce, or at least review some of these. One of the earliest ones was this Mse Ecmo System. And this came out of Australia. Andy Priebus was the primary developer of this. It's still out there. This website hasn't been updated in well over 10 years, and I don't know the current status of it, but it's one of the early ECMO simulators that's out there. The second one, which is probably much more familiar to all of you, is ECMO Joe, which came out of Hawaii. This is Marco Gino. Dr. Gino was I think, one of the primary authors of this work, and it's been around for a while. It hasn't been updated either in probably 5 or 6 years, but nevertheless is one of the mainstay simulation systems that we have. A brand new one out of Spain I know nothing about. It's called Hybrids Vita. It's you can see it's screen based and is brand new, at least to my knowledge, on the market. The last one I wanted to just mention briefly comes out of Columbia Presbyterian by Dr. Mark Dickstein, who is the primary author of this one. It's called Harvey by PV Loops. You can find it Harvey online, and it's pretty good. There's a lot of variables, and of course there's a lot of variables in these kinds of models, and allows you to sort of play with things and have fun. And those are the ones I know of. But I'm going to sort of introduce some of our shenanigans, what we've done, and this is a system we call Khalifa in the cloud, and it's a 3D environment, ICU, and I've got a little video of it here, and kind of shows some of the things that it provides. It has blood gases, which can be called up, lab reports. We have tags and various things that are all part of the simulation. But one of the primary features of this is the ability to have virtual devices that actually work. So here we are adjusting the FiO2 in our ventilator. We can also show chest films echoes, any kind of media, all part of the scenario that we might want. Here we have 4 leads hooked up with our Invos, which is actually working, and we can set the baselines right there. And of course, fluid administration is a big part of this. We have these infusion pumps, all adjustable and so on. We can pick different fluids that we might want to be giving, and most of the other devices are all equally interactive, or at least functional in that sense. Other things we can do with this is we can pick different cannulas. We can have different cannula sizes. Of course, the implication for pressure flow dynamics is obvious. The gas blender, we'll set that up right now, and I'll go ahead and give this some flow so that we can get prepared to go on ECMO. I'll put the FiO2 at 60. Now we'll come over here and we'll get this cardio help revved up. You can see, maybe you can see that there's a clamp on the line right now. And so I'm going to kind of gently bring the flow up to a pressure that's slightly above arterial, and go ahead and remove the clamp. And we're starting to flow now, and then I can go up and up. Now I think you get the idea. And what I'm going to do is I'm going to basically stop there and turn this over to Jeff, who's going to show you an example of how this might be used to teach specific ECMO principles. So Jeff, if I stop sharing here, I'll go ahead and turn this over to you. Allow
Thank you, Richard.
to, yeah, thank you.
Thank you. Richard put together 2 scenarios that I'm happy to share with you. And some of my cynical perfusion friends say there's not much to ECMO. If you can recognize recirculation during VV, and you can recognize the north-south syndrome during VA, that's all you need to know about ECMO. So we picked those 2 demonstrations here today with the 3D environment. And I'm going to start and stop these scenarios. And you can see that we can build these scenarios with probes to stimulate learners or to challenge learners. And we can also weave in, as Richard pointed out, we can weave in educational material. For example, if we want to bring up a picture of the circuit, we can also come offline in the simulation where the learners are being challenged, and we can put educational material up on the screen to help people understand. And the particular mode of cannulation that we've selected here is the right femoral vein with a long cannula to the base of the right atrium, and a return flow to the right internal jugular to the ceiling of the right atrium. And that's, of course, very helpful with first-time learners when you're trying to get them to appreciate how the cannulas may be laid out in front of them. We've brought up the hemodynamic monitor in the upper right-hand corner here, and you can ask the learner, what do you see that's normal or not normal? The CVP is a little bit high. The pulse oximeter is low. And that would suggest during VV that we're not getting the effect that we want. So we'd start looking around the room for other cues. And another place to go would be the cardio help screen to look at the blood flow. And we want to look at what this blood flow rate is compared to our patient size. This is a 70 kilogram patient, and they're about 43 mLs per kilogram per minute. And that's not too much flow for VV. As a matter of fact, it's might be a minimally acceptable flow. Plenty of venous return, it looks like, at 3 liters a minute at -4, especially with the elevated CVP. Um, but as we continue to look around, the one thing that has caught everybody's attention is the pre-oxygenator sat, or the SVO2 on the cardio help, is up to 95%. And you can see that both blood lines are red. And that is a clue in VV that we're recirculating, as well as the depressed or an unacceptable pulse oximeter value. So we're starting to build a story here that we have recirculation, and we've confirmed the recirculation. We can go around and check some other things. In the room, we had the capability to hook a CDI device to the circuit. And it, of course, reads the arterial blood in the circuit, going to the patient's right internal jugular. And you can see that this is pretty acceptable. There's a high DO2, a low oxygen transfer rate in the circuit because the venous sat is elevated. So the fact that there's plenty of volume, a -4 pressure venous would suggest to us that perhaps the cannula tips are too close together. Plenty of volume, plenty of flow. It'd be nice to go up maybe a little bit more in the blood flow. But if we had a chest x-ray, we could put up the chest x-ray right now and confirm that the tips are closer together than they should be. And the simulation is designed that we can actually change the depth of the cannula or rotate the cannulas, especially when we're thinking about the dual lumen cannulas, where rotation is important to align them properly. So we brought the surgeon in the room. We pulled the cannula back because we had diagnosed it as cannula recirculation. And once it's in a position where we think it's safe, then we can go back around the room and watch for changes that occur with repositioning the cannula, repositioning the patient. And that would start with the hemodynamic monitor, and we would hope that the pulse oximeter would start to rise, and it looks like it's up to 91 now on the pulse oximeter. And of course, on the lab screen, on the cardio help, the venous sat has come down to 75, and we have oxygen transfer in the oxygenator. The pulse ox has increased. If we drew an arterial blood PO2, right radial arterial blood PO2, it would be back up to a more acceptable value consistent with the 92. So this is a demonstration of recirculation with a simple VV model and some of the things that we can do with the 3D simulator. I'm going to switch to another scenario, and we're going to leave enough time to talk afterwards. The next one you'll see has the title Harlequin Syndrome. And as you probably know, we've taken great pains to have a separate instructors panel, and for instructors to be able to design scenarios step by step and put as many devices in place and probes in place to stimulate learners. Here we have a patient that, much like Dr. LaRusso's presentation yesterday, which was, I kept watching Dr. LaRusso in his presentation asking, can our simulator do that? And I think I was saying half about 2/3 of the time. And what we have here is for those of you who have been called to the ICU by the nurse, where they're saying the oxygenator is not working because the right radial blood gas has a low PO2. That used to happen 3-4 years ago, but I think ECMO teams are a lot smarter about the mixing cloud, the north-south syndrome, the Harlequin syndrome. This particular patient has a blood gas, right radial blood gas. The PCO2 is 42, the PO2 is 58, the arterial sat in the right wrist, the right radial is 91. And the team's concerned that the oxygenator is not working, that we have an oxygenator failure, and which is a common early diagnosis in the Harlequin syndrome if you're drawing blood from the right radial, which is most people's protocol. One way to confirm it is to go over to the left radial artery, and we have the capability to switch over to the left radial. And you can see here in the left radial, the PO2 is higher, it's 83, and the SAT's higher at 96. So there's a gradient, a difference between the left radial and the right radial, the left radial being higher. The patient has certainly has blood coming back to their body from the left femoral artery is where the cannulation is. If we look at the screen on the cardio help, we can see the venous sat 69. The flow rate is 3.5. Our patient, again, this is another 70 kilogram patient. This is a lower blood flow than we might want to be at, and this venous sat is okay. Great hemoglobin concentration, but we still have the problem with the gradient between the right radial and the left radial. The question, I think Ty even asked the question yesterday of Dr. LaRusso, if he uses NIRS devices. By the way, the sweep rate is set at 3.5, and the FiO2 is pretty low on the Sechrist, but there's nothing unusual there that is of concern. Ty asked if they'd use NIRS with the patients. They were ending up to put right internal jugular cannulas in to treat the Harlequin syndrome. And here's what a NIRS value set might be for where the right radial blood gas and the right side of the head, neck, and shoulders are getting less oxygen from blood being ejected from the left ventricle. And here's blood making it up to the left side, the left common carotid, to the left side of the head from the extracorporeal circuit with more oxygen in it, as we demonstrated with the two blood gases. Here's the thighs, the NIRS in the thighs, and you can actually set this up to show a gradient that would be experienced with cannulation of the left or right femoral artery, again, to do basic education for the folks. But let's continue on here. So we've sort of, well, we have confirmed that we have a difference in oxygen levels between the left side and the right side of the head, neck, and shoulders. So we're going to keep looking. The teams decided that in addition to our right atrial or inferior vena cava to femoral artery, right femoral artery return, we're going to split the outflow line and send flow up into the right internal jugular. In this particular case, we couldn't turn up the blood flow anymore. The P venous pressure was going negative. It turns out this cannula might be too small. I'm sorry, the venous cannula might be too small, not allowing us to hit the target blood flow. So the idea is to split the blood flow to send more oxygen to the head, neck, and shoulders. And you can talk about the pros and cons, including Dr. Russo's concern that once you split these lines, the line of least resistance becomes the internal jugular, and most of this blood flow coming out of out of your blood pump is going to take the path of least resistance to the head, neck, and shoulders, and you can get into trouble with that model. So you need to have some resistance here. And then we heard a great presentation from Dr. Patel this morning about left ventricular unloading in this model, and our inability to go up on the blood flow to get any help from this return, not to mention that that's not a sure cure to decompress the left ventricle anyway. We certainly can confirm that there's left ventricular output from the hemodynamic monitor. And wouldn't it be great to have pressure volume curves at the bedside? And we can do that with the simulator, and our next hemodynamic model will give us that capability. Continue on, here our circle around the patient. Here's the split in the arterial line, and there's a Hoffman clamp. I thought it was very clever that Dr. LaRusso had an electronic clamp on here, and I'm definitely going to steal that idea. There's a flow probe in place on the IJ line, so we'll know what that flow is, as we were warned yesterday by Dr. LaRusso to measure those flows. The Hoffman clamp is on there. It's been opened a little bit, and as we were instructed yesterday, it's important to measure the flow in that limb. Right now, there's about 300 cc's a minute going through the IJ line. There was 3.8 coming out of the cardio help. So we've robbed 300 cc's of that off to the IJ, holding it back with the Hoffman clamp. And we'll look for some sign that we're getting oxygen to the head, neck, and shoulders through the VV limb. And indeed, we can see that the right nears is coming up to meet the left nears. So we've reversed a little bit of this Harlequin syndrome or the mixing cloud that's going on. So the team's determined that they want some more flow. They come back to the Hoffman clamp. We're going to open the Hoffman clamp more to get more of that arterial blood going to the great veins and to the pulmonary artery. And now the flow is 1.3 liters a minute. Again, 3.8 total out of the cardio help and 1.3 diverted. The femoral artery is getting the difference. So we would expect in our nears to see an improvement. And the left and right nears are reading more consistently now, and we've reversed the Harlequin. Now the blood's still going through the left ventricle and blood's still going through the lungs. There would be a consideration about how the ventilator was set to ventilate that blood. Presumably, you didn't want to go up more on the ventilator settings to try and oxygenate the blood in the left ventricle more because of possible barotrauma, which would be the stimulus for putting in the right IJ line and going VA-V. And so we've confirmed that we've reversed the VA-V. And it's even to the point where we could bring somebody into the room, like a respiratory therapist, to change the ventilator settings or to help us draw blood gases. But possibly with the VV limb of the VAV, the ventilator wouldn't have to be set quite as high as long as the left ventricle was able to pump the blood. To Dr. Patel's points, we don't want to hurt the ventricle, but if the ventricle was able to keep up despite the lungs not being able to. You can see there's different things. We can have people come into the room. Here's all the possible sites that we can draw blood gases from to help learners. And I'm going to stop right there and leave 5 minutes for questions. thank you very much for your attention.
Well, so I guess you answered my question from yesterday. I mean, it seems like the cerebral oximetry did help you quite a bit during your ECMO.
Yeah, and we didn't make that up. We actually got real clinical data from teams in Minnesota and teams in Washington State. And they'll put 4 pads on. They'll do shoulder, shoulder, leg, leg, and look for gradients.
Jeff, where are we with this whole simulator at this time as far as distribution, usage for the clinical setting, or for people that want to utilize it for teaching in their own programs?
Richard?
Well, that might be a question for me. It's basically ready, but we haven't really rolled it out yet. It's going to be probably beginning of May. We'll start talking about it openly, but it's that close. The next step is for us to use our real equipment with it. And what happens in that case is if I wanted to use a real cardio help connected to Khalifa, then the pump in this picture would disappear, and you can still use all the other devices. Let's say early May, we'll probably formally announce it and make it available. So that's not very far. You can see it's basically all ready to go, except minor bugs, this and that, and we're still want to polish it some more.
Right. So this is a high fidelity,
right?
Well, I guess high fidelity virtual program.
Yeah.
As compared to a high fidelity Khalifa, which connects to your pump. How are you going to distribute that, and how would we purchase that?
Well, it starts off by being cloud-based. That was one of my slides that I kind of glossed over, but meaning that you could use any device, right? So anything can run it. And it's starting off, it'll be a license, so an annual license. But we want it to be available with our hardware too. So it's going to be the next version of software rollout with our hardware. We'll have this as part of it, but by itself, it'll be a cloud-based license format.
So if you buy Khalifa, then you're going to have the
You'll
software.
have it. Yeah.
But you would still pay a license per year for the software?
No. It comes with it. And if you've bought Khalifa in the last 6 months, you'll be automatically updated to get this. It's the cloud version that's the license. If you buy Khalifa, it comes with it. Yeah.
Thank you. Those were several questions in the chat room.
Okay.
Also, people were asking about, will you have disaster drill setups? I know that Jeff mentioned a few instances there with the.
Well, we've got a couple things. We can disconnect the gas line, and then you have to diagnose that. Other disasters, the patient can lose a lot of blood, and we can clamp on lines. We can occlude lines. So there's a few things. The patient can get very, very sick. Of course, the scenario can drive that quite directly.
Yeah, we can actually take away the surface area of the oxygenator too, and mimic clots in the blood path.
Yeah.
And change the pressure drop across the oxygenator.
Yeah, Jeff, I could imagine a strategy written where the teacher wants a certain thing to happen, and you just program that in, and everything falls in place with the class, with the oxygenator, with the SATs, everything in order. Might be a cool thing to have as an instructor.
Yeah, since all these monitors are reflexive, you don't have to do very much. They'll all reflect the disaster. So partially occluding one of the lines or something, you'll see everything change automatically. Yeah. I see Dave is on the line. Hey, Dave.
I see Mayo Clinic is interested. Call us.
Well, it's an update to the software that they have, than they own. But the problem is, I mean, the difficulty is this is gaming, and it requires graphic processors that are in excess of the regular laptop. For those of you who do gaming, you know, it takes a higher level computer. That's really all. Yeah.
Does it use the Unreal Engine?
Yeah, Unity. Yeah.
Okay.
Unity. It's all done in Unity. And well, of course, all of our algorithms are working in the background and driving this, but it's the Unity that makes this happen. And we can have different avatars come and go. We can have them talk and yell, and that can all be part of a scenario as well.
I guess because of Dr. Patel's talks, somebody was asking if we could add an Impella to it at some point.
Well, you know, I'd like to, all the different devices, I have to get them to answer my calls and help me with a 3D rendition of their device. We'll do it. We'll put anything in the room. By the way, the OR is going to be next. That's what we're working on now. So it's all ICU for this go around. The next go around, we'll have the full OR environment.
I mean, I think it'd be fascinating to see it in conjunction with the equipment if you're in the room with your cardio help, your SAE, or your Spectrum Medical,
Yep.
and being able to utilize that. I don't know how exactly that's going to work, but it's going to be fascinating. But even being able to teach on Zoom sessions when you can't be in classroom and teach little clinical scenarios like this, I mean, my head's woohoo! I can do it like tomorrow with several of our accounts within perfusion.com. So yeah, I'm excited, man.
Good. Glad you like it.
Thanks for the opportunity to share it.
Yep. Thanks for the invitation.
Well, thank y'all. It's going to be, I mean, this looks like one unbelievable teaching tool, and it takes people like you to drive us to the next level, which both of you have always done. And I really do thank you for what y'all bring to the table in perfusion. So again, and education, the educational value. So thanks again.
Thank you, Ty.